Welcome to this high-yield review of pulmonary embolism for Step 2. Our goal is to master the diagnostic algorithms and identify the next best steps in management. By the end of this review, you should be able to confidently approach any PE question on your exam. Pulmonary embolism is defined as an obstruction of the pulmonary arteries, most commonly by a blood clot. It falls under the umbrella of venous thromboembolism, or VTE, which also includes deep vein thrombosis. One critical distinction for Step 2 is whether a PE is provoked or unprovoked. This directly determines how long you anticoagulate the patient. Remember, 90% of PEs originate from proximal DVTs in the iliac, femoral, or popliteal veins. Calf DVTs rarely embolize. The primary risk factor framework for PE is Virchow's triad: stasis, endothelial injury, and hypercoagulability. Beyond thrombotic causes, remember the mnemonic fatal for non-thrombotic emboli: F for fat emboli from long bone fractures, F for air emboli from central lines, T for thrombus, the most common type, F for amniotic fluid emboli, seen postpartum and associated with DIC, and L for less common causes like bacteria, tumor, or bone cement. When a clot obstructs the pulmonary artery, it creates a VQ mismatch. Specifically, increased dead space, where ventilation occurs without perfusion. If the clot causes infarction, pleural inflammation leads to pleuritic chest pain. Within 24 to 48 hours, surfactant dysfunction causes atelectasis. The classic EBG pattern is hypoxemia with hypocapnia due to hyperventilation, resulting in respiratory alkalosis. High-yield pearl. A widened alveolar arterial gradient is almost universally present in PE, even when the PaO2 appears near normal. On the cardiac side, PE causes acute right ventricular pressure overload due to increased pulmonary artery pressure. This leads to RV dilation and a septal shift toward the left, which reduces LV preload and drops cardiac output. A saddle thrombus at the pulmonary artery bifurcation is especially dangerous and can cause sudden death. The key Step 2 pearl here: hypotension in massive PE is not from blood loss. It is obstructive shock from decreased left ventricular output. The classic presentation of PE includes sudden onset dyspnea in over 75% of patients and tachypnea in over 70%. Pleuritic chest pain, sharp, localized, and worse with inspiration, suggests peripheral infarction. Hemoptysis is another clue. Always ask about unilateral leg swelling or pain, which suggests an underlying DVT. The most important clinical pearl: if a patient presents with acute respiratory distress, but has clear lungs on auscultation, think PE until proven otherwise. Massive PE is defined by hemodynamic instability, a systolic blood pressure below 90 Hg, or a drop of at least 40 Hg sustained for more than 15 minutes. Syncope may be the presenting symptom. On physical exam, look for jugular venous distension, a loud P2 component of S2, and a parasternal lift indicating right ventricular heave. These findings point to acute right heart strain. When you suspect PE, always start with the ABCs: oxygen and IV access. Then obtain a chest X-ray, ECG, and ABG to rule out other diagnoses like pneumothorax or ACS. The critical third step is to assess hemodynamic stability and calculate the Wells score to estimate pretest probability. This determines your entire diagnostic pathway. Always assess stability first before ordering any imaging. The Wells criteria assigns points to clinical features. Clinical signs of DVT and PE being the number one diagnosis each earn 3 points. Heart rate above 100, immobilization for more than 3 days or surgery within 4 weeks, and prior DVT or PE each earn 1.5 points. Hemoptysis and active malignancy each earn 1 point. A total score greater than 4 is considered PE likely. 4 or less is PE unlikely. Memorize these cutoffs. They are the gateway to everything else. For a hemodynamically stable patient with a Wells score of 4 or less, the next best step is a D-dimer assay. If the D-dimer is negative, below 500, PE is effectively ruled out and no further imaging is needed. If positive, proceed to CT pulmonary angiography. Critical pearl: D-dimer is a rule-out test only. It has low specificity. Never order it in high-probability patients because a positive result won't change your management. You're going straight to CTPA anyway. For a stable patient with a Wells score greater than 4, skip the D-dimer entirely and go straight to CT pulmonary angiography. This is your gold standard for diagnosing PE. If CTPA is contraindicated due to contrast allergy or renal insufficiency, use a VQ scan instead. An unstable patient cannot safely be transported to the CT scanner due to the risk of cardiac arrest en route. In this scenario, the next best step is a bedside echocardiogram or point-of-care ultrasound. The key finding is RV dilation or strain, particularly McConnell sign. If echo shows RV strain in an unstable patient, treat for massive PE immediately without waiting for confirmatory imaging. The most common chest X-ray finding in PE is a normal chest X-ray. This is itself a high-yield fact. However, 3 classic, though rare, findings are worth memorizing. Westermarck sign is focal allogemia, or decreased vascular markings. Hampton's hump is a peripheral wedge-shaped opacity indicating infarction. And Fleischer's sign is enlargement of a central pulmonary artery. Remember, a normal CXR in a hypoxic, tachypneic patient should immediately raise your suspicion for PE. The most common ECG finding in PE is simply sinus tachycardia. The classic finding that Step 2 loves to test is the S1Q3T3 pattern, an S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. This pattern reflects acute right heart strain from the increased pulmonary pressure. However, remember, it is neither sensitive nor specific. Sinus tachycardia alone should keep PE on your differential. A VQ scan is the preferred imaging modality when CTPA is contraindicated. Use it in patients with contrast allergy, significant renal insufficiency, or in pregnancy, where it delivers less radiation to breast tissue than CTPA. Step 2 Pearl. If the VQ scan result is indeterminate or low probability, but your clinical suspicion remains high, the next step is either CTPA or lower extremity Doppler ultrasound to look for DVT. PE severity is classified into 3 categories. Massive PE involves hemodynamic instability or shock. Submassive PE is normotensive, but shows evidence of right heart strain. Elevated troponin or BNP, or RV strain on echo or CT. Non-massive PE is normotensive with no biomarker elevation and no RV strain. This classification directly drives your management decisions, particularly regarding thrombolysis. For most stable PE patients, low molecular weight heparin, specifically enoxaparin, is the preferred initial anticoagulant. However, unfractionated heparin is preferred in 3 key situations: renal failure with a creatinine clearance below 30, hemodynamically unstable patients where you may need to stop anticoagulation quickly for surgery, and massive PE where thrombolysis might be needed, since UFH can be rapidly reversed. Reperfusion therapy is indicated for massive PE. Systemic thrombolysis with TPA is the first-line reperfusion strategy for massive PE with low bleeding risk or for patients in cardiac arrest. If TPA is absolutely contraindicated, such as in recent hemorrhagic stroke or intracranial tumor, the answer is surgical or catheter-directed embolectomy. Know your absolute contraindications to TPA cold, because Step 2 will test them. Inferior vena cava filters are placed in only 2 situations: when there is an absolute contraindication to anticoagulation, such as active major bleeding, or when anticoagulation has failed and the patient develops a new PE despite being at therapeutic levels. Do not place IVC filters prophylactically or in patients who can safely take anticoagulants. This is a common Step 2 trap. The duration of anticoagulation depends entirely on the cause. Provoked PE from a major transient risk factor like surgery is treated for 3 months. Unprovoked or idiopathic PE requires 6 to 12 months, or indefinite therapy. Cancer-associated PE is treated indefinitely with LMWH or a DOAC for as long as the cancer remains active. If using warfarin, bridge with heparin for at least 5 days, and until the INR is between 2 and 3 for at least 24 hours before stopping heparin. Let's wrap up with the highest yield points for Step 2. For diagnosis, Always assess stability first. Unstable patients go straight to bedside echo. Stable patients with low Wells score get a D-dimer, and high Wells score go directly to CTPA. For the Wells criteria, remember DVT signs and PE as top diagnosis each give 3 points. For management, stable patients get LMWH, unstable or renal failure get UFH, and massive PE gets TPA. If TPA is contraindicated, the answer is embolectomy. IVC filters are only for anticoagulation contraindication or failure. Duration. Provoked PE is 3 months. Unprovoked is 6 to 12 months or indefinite. And cancer-associated PE is treated indefinitely. Finally, remember the classic Step 2 traps. Clear lungs with dyspnea means PE. Hypotension in PE is obstructive shock, not blood loss. And a normal chest X-ray does not rule out PE. Good luck on your exam.